Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm your host, Leo Arguelles, and in today's episode, our guest is Galen Schram. Galen is a board-certified clinical specialist in oncologic PT and is a faculty member of the Acute Care PT Residency program at Rusk Rehabilitation at NYU Langone Health. Galen and his OT colleague, Emma Kiernan, will be leading our upcoming free webinar through APTA Acute Care's practice committee titled Enhancing Outcomes for Hematopoietic Stem Cell Transplant Patients Through Interdisciplinary Rehab. In today's episode, we discuss how Galen became involved in acute PT, the events that led him to work with the oncologic population, and how narrative medicine plays a role in our profession. Enjoy the show. All right, welcome to the Acute Conversations podcast. For today, our guest is Dr. Galen Schram, who is also going to be doing a practice webinar, or for our practice committee, he's doing a webinar for APTA Acute Care. We'll talk about that a little bit later in the episode, but the webinar is scheduled for July 30th, and we'll give some more details. Galen, thank you so much for being here today.
Oh, thank you for having me, Leo. It's nice to be on this podcast.
Thank you very much. And so, before we dive into actual what your webinar is going to be about, I wanted to take this podcast opportunity as a chance to maybe just talk about who you are and how you got involved working with this specific patient population. And even before that, how you even got into PT. So let's start off with that. How did you become involved in physical therapy and then into acute care?
Yeah, those are good questions. How we got here. I've been a practicing PT now it'll be 9 years this summer. So it feels like I've been here for quite a while. But I was an undergrad student, and I had such an interest in like my science classes and my anatomy classes, and I wasn't sure where I wanted to go within that initially. But I was interested in science, and I've always liked working with people, so I knew I wanted to do something related to patient care. So I took a semester and I shadowed a few different professionals. I shadowed a nutritionist who worked in a hospital for a while. I shadowed a pediatrician also. And I also was with a physical therapist who specialized in chronic pain. And she did a lot of stuff with aquatic therapy at the time. And I remember thinking how cool that was, like the difference that she was able to make with her patients. And I also really liked that she was able to work with people for longer stretches of time. So everyone that I kind of got to shadow as a very young person, I liked the relationships that she was able to build. So it was really because of her. And this was at Shands Hospital and University of Florida in Gainesville that I decided to apply to physical therapy school.
Fantastic.
So that was, a long time ago, 2013, I enrolled.
Wow.
Thinking I was going to go kind of the orthopedic sports route.
You're already here about this. Okay, so let me take a step back. So I feel the different healthcare providers that you were shadowing, were they all in hospital system, or are they also like outpatient too? Or
the pediatrician I shadowed was a little bit of both, some hospital experience and outpatient clinic. The nutritionist was in the hospital, and then the physical therapist was strictly outpatient. So very different from what I do now.
Exactly. And so when did it dawn upon you that there is this thing called acute care physical therapy? Because a lot of people don't know that this even exists, even us within the profession, which is probably a knock on us because we don't do enough marketing. We don't I think market ourselves well enough to the regular population. So how did you stumble upon acute care physical therapy?
So I worked at NYU Langone Health, and during one of my clinicals, I did outpatient orthopedics here at NYU. So I knew I had some wonderful teachers and mentors, and my intention was to graduate, and I wanted to work there. That's what I had my heart set on. I had taken all these advanced orthopedics and sports classes during PT school. But in order to work in the outpatient ortho clinic, I was told I needed to start in acute care. I needed to do a rotation in the hospital. So I accepted this job kind of just to get through my year of acute care in order to reach like the outpatient orthopedics on the other side. So I started working in the hospital, and I found I really enjoyed connecting with patients when they were admitted. I think there's a level of vulnerability that patients have that we work with that felt very meaningful to me. So teaching people to walk again after a stroke or after a big surgery, it felt a bit like weightier than what my original goals were. So after a year, I decided to stick around, and here I am 9 years later.
So it was supposed to be like a pit stop en route to going into the whole orthopedic route, and yeah, you fell in love with it and you never left.
That was the plan, and then that's what happened.
I remember my high school quote was, I think it's from John Steinbeck: "The best laid plans of mice and men sometimes go awry." It's like we've got these plans set up, and something's happened. It's just and it's funny because at the time we have no idea. I'm thinking about my students right now. If I told them before you work in the outpatient sector, you're gonna have to do at least 6 months working in acute care, they would be livid. They would be so upset having to do that. But now, when you look at the situation in your particular situation, it's like you fall in love. So yeah, talked about how much more meaningful or the relationships you connected with patients. But now looking at, for example, this webinar, you're talking about oncology or patients that are on the oncology ward. So how did that relationship start, or how did you end up working with that population?
Yeah. So at NYU, it's really nice that we have it set up. So I started working here as a brand new grad. At the time, I had never even done an acute care affiliation, which isn't really the case anymore with the people that we hire. But at the time, I had no experience. So I was set to rotate through each unit of the department. So, we did like 3 to 4 months on cardiac surgery. We did like 6 months in neuro, 6 months gen medicine. And oncology was almost a forgotten field. Like we would go there for just a few months. There wasn't a whole lot of mentorship at the time, as our staffing was much less than it is today. There weren't as many concepts when I was first starting compared to today.
Yeah.
But it was a program that when I was a staff physical therapist here, that kind of some of the leaders within the hospital and within Rust Rehab in particular, they were trying to build a program. So when I rotated through my oncology specialty, I identified that there was a big gap. I thought there was so much more that we could be doing for this patient population that we didn't have the resources or the training for at the time. So I expressed this to my supervisor during my annual review, that oncology seemed like almost a neglected field of physical therapy, a very growing field that just hadn't been fully expanded yet. And the stars kind of aligned because my managers were looking for a staff PT to kind of take this program on and expand it and grow it into what it is today. So I was young. I didn't know what is it. I knew what I didn't know. Like there was so much to learn that I just didn't know. But I wanted to learn it, and I wanted to be with this particular patient population that I think is very unique in the hospital setting. We cover both surgical and non-surgical services. We cover like all phases of survivorship, from new diagnosis to like maintenance therapy to palliative and even end of life care. So the opportunity to get to know patients on a really deep level and really be there for them in a way that is curtailed to the needs of each patient, it just felt so meaningful and unique. And there was so much opportunity there. So this was several years ago now. And it was a great opportunity for me too, as like a kind of younger therapist to I was encouraged to take a lot of continuing education classes. So I learned from a lot of experts around the country what was possible to do with these patients, many of whom survivorship was improving from their disease, but they were surviving with, functional mobility deficits that was now relatively new for our profession.
Right.
So learn about how to address these deficits in real time and then implement them the next day in clinic was pretty cool. Yeah, so this was a while ago, and then since that time, I worked with that patient population, and now I'm a clinical manager, so I help train staff as they rotate through their oncology rotation within the hospital.
Very cool. And also, in terms of your specialization, you're also a clinical specialist within the oncology realm, right? How long ago was that?
Yeah, no, it was 3 years ago. I just completed my very first MOS.
Oh, yeah. It's very good. For those people that don't understand, the MOS is that once you're a clinical specialist, right? I think it goes like every 3 years, you have to complete a little bit of extra work. Almost like, I don't know what they do for the oncology section. Do you have to do like a case report or like
Well, this was the first. So MOS stands for a maintenance of specialist certification. So every 3 years, yes, there's a number of requirements that you need to just show that you're continuing to learn and grow and contribute to the field also. So I was actually kind of fortunate that I did not have to write a case study this go round. I will in years, but there was a number of other things. Like I've been fortunate to do a number of presentations at CSM and some in-services, and I have a lot of mentorship hours. So these are the kinds of things that the oncology section is looking for its members to do in order to maintain their specialization.
That's fantastic. Now, I do want to get to that opportunity where you presented at CSM, because it very much ties into this opportunity for the webinar. But before that, one thing I wanted to ask is, when you had this opportunity to start working with oncology patients, how long ago was that? Was you said that was early in your career?
Yes, I think I've been working for 2 years, so
All
that
right.
was 7-ish years ago.
Wow. Okay. So within the past 7 years now, how have you seen the field of oncology rehab evolve, and how has it changed?
I know I can say for sure that we're getting consulted for a lot more patients
Good,
than we used to, which is
good,
great. I
good.
think it's very standard that when a patient gets admitted to the hospital with a new cancer diagnosis, that they'll get a physical therapy and occupational therapy consult, just to kind of set a baseline, establish what
Mhm.
the needs are, and make recommendations for any continued follow-up care. So that's huge. I think we've also got a lot of very robust programs in the hospital that didn't exist before. And it's all based off of literature that's been published within, the last, even the last 5-10 years
Yeah.
within the field of oncologic physical therapy. The BMT program is I love that patient population. And a lot of what the program that we have now is based directly on a number of systematic reviews that have come out really since, well, like 2018 and a little bit before too. So the research has blossomed, the patient consults have blossomed. There's a big need.
It's funny just thinking back that where we're at now, when you think back like 5-10 years ago, that PT and OT it was not an automatic consult, right? And I think that that was a disservice for patients, because we see now how beneficial that is. But one thing I think is of note is that the medicine of survivorship and the different medications, the different, from a pharmacological standpoint, in terms of just, well, we'll say survivorship has gotten better. The medicine has gotten better, but along with that, there's this need for therapy services of what we can provide, right? Because now this life that, there's going to be a change in a patient's life, and there's probably going to be some loss, and there's probably going to be some adjustments, and that's where we come in, both PT and OT, to kind of help make some of those adjustments. So it's wild to think how that wasn't consulted, or how we were not consulting before, but also how important we are in terms of the whole healthcare system working within this population.
Yes, absolutely. I'm a big fan of the prospective surveillance model. I think in acute care, historically, if someone can walk, they don't put in a consult for physical therapy,
Mhm.
which is kind of the mainstream. That's the way things work oftentimes. But a
Right.
lot of the patients that I'm seeing are ambulatory, but it's still worthwhile for us to go in and do an assessment, provide some much needed education. I have all staff that work on the oncology population screen every single patient for CIPN. This is often like something that can go underdiagnosed, and just provide education about what maybe to expect, when to reach out to an outpatient therapist, when to ask for an outpatient therapist. These are all the opportunities that we have when a patient's admitted to the hospital. Education is one of our most important interventions for sure.
Absolutely. What did you say, CIPN? What does that stand for?
Chemotherapy induced peripheral neuropathy. So
Uh,
yes, I'm a part of a kind of a subcommittee at NYU that's looking for making sure that all patients who have therapy-induced peripheral neuropathy are seeing the proper professionals, PT and OT. We have a lot to do with helping patients navigate life with CIPN and make gains. That's just an example of one initiative that we're working on.
and that's so funny how far we've come, but yet we're still battling this, being kind of judged as only the ones that kind of walk patients, right? We're kind of saying, okay, the therapist here, we're here to walk the patient. Or if this patient is walking, they don't need physical therapy, which limits us so far in terms of what we can offer to these patients, right? And I'll allude to it a little bit later too, is that in one of your writings that you are actually won an award for, I love your reference to the Band-Aid therapist, right? We as Band-Aid therapists kind of like, let me just see if this patient can walk, and we can just help with the throughput and get them out the door. But that severely limits what value we offer, and we can offer to both patients and for the whole healthcare team.
Yes, absolutely. I agree. I think, and especially in oncology, because we'll get patients admitted for like induction chemotherapy, and they'll be in the hospital for 2-3+ weeks. And
Mhm.
even if they can walk into the hospital like that, our goal is to keep them ambulatory, keep them walking, keep them
Right.
strong. And I think historically, those patients were a subset that were not being consulted for PT and OT. And I think to their detriment in the long run, for sure.
So then what happens to a patient? Like, what connections do you have with patients once they leave the acute care side of things? Is there any follow-up in terms of what you can do, or is there any type of like communication with like referrals to outpatient? What happens after that?
We've got a few programs where it's kind of just standard that a patient will go home with an outpatient, either physiatry or physical therapy consult. So BMT is one example. We try to follow that patient population through the continuum of care. So they'll start every patient who's being worked up to be a candidate for a stem cell transplant will be referred to outpatient physiatry, who will then refer them to outpatient physical therapy to get kind of a baseline assessment, help them improve their strength as much as possible to get them ready for that transplant. When they're admitted to the hospital, they'll fall under my care or one of my colleagues' care, and we'll treat them while they're in the hospital. Then they discharge home, and once they get the clearance from their doctor with their white blood cell count to resume working out in the gym, then they'll return to our outpatient PT colleagues. So we also have the ability to make discharge recommendations for all patients. That's one of our major roles in acute care, of course. Making a referral to outpatient PT when appropriate is also something we can do from the hospital setting. And educating patients about maybe they don't need PT right now, but they might need it down the line, and educating the patient themselves about when to advocate for their own PT when they visit their outpatient oncologist. That's also something that we do.
Right, that education component. It's so funny, this working in academia, working with students is the impact. I don't think they realize the impact that we have as therapists in terms of providing education. They're very much in the realm of, okay, what are the exercises? Where's the diagnosis? Let me do the diagnosis, and what's the treatment for this? But that education component so that the patients can become advocates for themselves is huge. And I think sometimes we take it for granted.
Yes. And some providers I think are very rehab friendly. So like some of the nurse practitioners that I work with, like they ask about function as part of their assessment on like an outpatient basis. They'll make the referrals themselves, which I think is also something that's relatively new. Like the questions that are being asked of patients by their non-rehab clinicians, and funneling them to get them the care that they need too. So I think like our relationship with the teams upstairs is also very critical, because it's kind of like educating the educators,
Right.
about when to refer their patients to the PT and OT outside of the hospital.
Right. I mean, that's what it's going to take, right? If we're so upset that we think that everyone thinks that we just walk patients, but if we don't say anything, if we don't educate, like you said, if we don't educate the educators, if they value what else we can bring to the table, if they're not helping find referrals for us and say, okay, asking a simple question in terms of just their patient's function at home to trigger a referral, now we can that's our foot in the door, which is fantastic. So
Yeah.
we had mentioned that you were able to present at CSM with all the literature that's come out and all the work that you've done. How did that opportunity come up for both you and Emma, your OT counterpart? How did that opportunity come up for you to present at CSM Houston?
Well, it started kind of 2 years ago. When I presented at CSM in San Diego, California, and I was invited to be part of a programming session, which was all about rehabbing the patient being worked up in status post a stem cell transplant across the continuum. So from the outpatient to the acute side to the outpatient. So I was with a team of all PTs, some wonderful colleagues. I represented the acute care portion of that presentation. And that was my first experience presenting programming at CSM. I was very nervous, but it went great. I had some wonderful mentors. So this programming this past February in Houston was my first time kind of spearheading a presentation. And I kind of took that idea that we had before, and I really wanted to hone in on the acute care side of it. And I wanted to expand it to show how we collaborate with other team members. So I'm fortunate to have some really great relationships with some of my colleagues upstairs. So I approached one of my social work friends, my occupational therapist colleague, and a nurse practitioner with my idea of presenting the interdisciplinary collaboration and how we all work together to rehab our patient. So that was the idea that I pitched to the APTA just over a year or so ago. And it was fortunate. I was lucky to be accepted. So we presented, yes, in Houston, Texas this past February.
Fantastic. And I think it provides, when you're working with an interdisciplinary team, you've just got more brains, more hemispheres of brains involved to be able to brainstorm and come up with solutions. So what does that add? What value does that bring once all those minds are working together? How can you help, or how does that help out for your patients?
Yeah, I feel like it all comes down to like the patient's experience. Like I want them, what they're going through is just so unbelievably hard. Like everything that they're experiencing, being away from home, being severely anemic and thrombocytopenic for so long, all the medications, the sleep-wake cycle being messed up, the diet. So anything we can do to optimize that experience to make it better for them. I mean, in addition to shortening the length of stay, it just makes it so much better. So one example is I attend interdisciplinary rounds every Tuesday. So I hear from the nurse practitioners medically how the patients are doing. Based on my own chart reviews and hearing the nurse practitioners and the bedside nurses describe how the patients have been lately, I make a decision about which of my patients are candidates to go to my gym class. So every Tuesday we host a gym class for patients who are medically appropriate and have the approval from their medical providers. So based on my input from the nurse practitioners, that's how I help decide which patients will make the best candidates for that gym class, who will have the most success, who's getting close enough to discharge that I really want to optimize their strength for a full discharge. So that's one example. I think also social work brings a lot to the table too about what patients are going through from like a social perspective. Their family dynamics is always playing a huge part in how we care for our patients. So they've been really essential in helping me incorporate family, for example, when it's appropriate to.
Absolutely.
Yeah. And we're all at interdisciplinary rounds. So it's a great chance for us to get on the same page kind of about what a patient needs.
Right,
So
right,
their chance. We want everyone to go home. So that's
right. And then sometimes I feel that, again, like you're working with your patient, I feel that we garner so much rapport and we get so much trust from our patients. Sometimes they'll give us information that maybe not the rest of the team know about, or they feel comfortable enough to share it with us. But that's such an important facet of their healthcare, to be able to communicate with the rest of the team, whether it's a nurse practitioner, whether it's the OT or the social worker. And as I'm listening to to how how the interdisciplinary team works, one thing I kind of want to get the perspective from is, so the patients that you're working, can you tell me about the patient experience from their perspective? So, they get diagnosed with some type of with a specific type of cancer where they're going to need the stem cell transplant. So walk us through kind of what happens in that situation from the patient perspective.
Sure. Yeah. So a patient is first diagnosed with some kind of, oftentimes a blood cancer. It doesn't have to be a cancer in order to be a candidate for a stem cell transplant, but most of the patients I work with have some kind of hematologic malignancy. So kind of a stereotype of what a trajectory might look like is a patient will be admitted to the hospital for these funky symptoms that the doctors suspect is some kind of cancer. Will diagnose the blood cancer, and they'll provide patient with what's called the induction therapy. So that's the first line, best evidence-based medicine to attack that cancer. Oftentimes patients are in the hospital for that, but you don't have to be. And it depends upon how the patient responds to that first line induction therapy. We need our patients to show that their cancer is responsive to that induction therapy in order to be a candidate for the stem cell transplant. So usually patients will be admitted for their induction therapy, which also kind of ravages their immune system, and their blood labs are all over the place. But once they're in a stable place, they often will go home. They'll follow up with their outpatient provider and kind of see how the cancer is doing. When they're in remission, they'll be potentially deemed a candidate for a stem cell transplant. So then they'll be readmitted to the hospital, where they'll receive a conditioning therapy. So this is yet another round of chemo or radiation or a combo of those things. The purpose of which is to really just eliminate as many of the cancer cells as possible, and to get rid of the body's ability to produce their blood count. So we're getting rid of their stem cells, kind of a byproduct of this conditioning therapy. Sometimes that's the goal too. And so then patients need the transplant to replenish the body's ability to produce their red blood cells, their white blood cells, their platelets. So, and they'll be in the hospital for maybe 7 days getting their conditioning therapy, that-ish, around there. They'll be transplanted on day 0, and then they're in the hospital until they reach what's called engraftment. So when that stem cell engrafts in the body and the patient starts producing their own red blood cells, white blood cells, and platelets once again. And then once they reach certain milestones, then they'll discharge home with continued outpatient follow-up. So it's a lot of hospitalization for these patients. Yeah,
Yeah.
first their induction therapy oftentimes, and then again for their conditioning therapy, and then for their stem cell transplant, waiting for engraftment.
And this physical therapy or the PT and OT team, there's multiple stages where they get involved in terms of the patient's care.
Yes, now it's very standard practice. When I first started on the floors, we would barely get consulted, only if there was an issue with their mobility.
Wow.
So how it's very standard practice. Someone comes into the hospital for that first induction therapy. So this is before the stem cell. They'll have a PT and OT consult.
Fantastic.
They get them oftentimes on some kind of exercise program. So they're educated, they're provided with the education about the benefits of exercise and activity for all cancer survivors. And we some specific guidance for those, what they can do, especially while in the hospital. And then we check in with them as needed throughout that hospitalization. And then once again, when they get readmitted for their stem cell transplant, same thing. We try to do our evaluations prior to day 0 or the transplant day. And then we follow up with them 1 or 2 times a week as needed until discharge, both PT and OT.
Fantastic. That's great to see again how we can become involved, and it's better to kind of manage things on the front end rather than after the fact, right? And now we have this patient that's been, has gotten weaker and weaker, and then at the end of their stay, that's when they consult therapy. And when you look back at it, it's like if you hadn't gotten me involved the 10 days prior, all these sequelae, these detriments of immobility could have been taken care of. So that's great that you were able to kind of implement and make that change in the hospital.
Mm-hmm. Exactly. Yeah. We're trying to do like preventive physical therapy. We talk about the DEETS model, cancer rehab in this presentation, for example. And a big part of our role is preventing deconditioning or preventing deficits that may take place were we not to provide our interventions. So that's a big part of what we do with this program too.
So just for our listeners out there, again, it's Wednesday, July 30th. In terms of the times, again, because it's all across the U.S., it's going to be 7 p.m. Eastern time, 6 p.m. Central, 5 p.m. Mountain, 4 p.m. Pacific time, July 30th, a webinar put out by the practice community for APTA Acute Care. Now, one thing that we talk about, especially on this podcast, is how to get published, right? And how can I run a study and be published in a reputable journal? But Galen, you actually won an award for your writing, not necessarily scientific writing. I wanted to maybe end on that, where can you talk about that award? I think it was through the Bellevue Literature Review or Bellevue Review?
Yes, the Bellevue Literary Review. Yes. So, thank you for bringing that up. Yeah, I like so one of my hobbies is always I love writing. I love reading and writing, and I love a good story. So I took a few courses through Columbia University in the field of narrative medicine, which kind of combines the humanities with like clinical care. And they advocate in this program. I learned to kind of approach like the patient interaction kind of like a narrative that I get to play a very specific role for each patient. So one of the courses I took through this narrative medicine program was a creative writing class. So in this class, we all wrote, either a poem or a short story, fiction or nonfiction. And I wrote a piece of fiction kind of based on a patient experience that I've had as a PT in the hospital. And that story I wrote for that class ended up being the very first piece that I ever got published in a literary journal. That was in Intima, a journal of narrative medicine. And around the same time, this happened to be as the pandemic was hitting us in 2020. And it was just so bizarre, the pandemic. We were reminiscing about this before that we were recording. So one thing I wanted to do was just kind of write about the experience. That was one of the things that I did to kind of cope during that time. So I wrote a fictionalized version of I had experienced during the pandemic in a story called Tattoos, which I then submitted into a competition through the Bellevue Literary Review. And I happened to win first prize for fiction that year. So that was published before. Yeah. And I really enjoy, I always say like I'm a human before I'm a physical therapist. And I think my writing is one way that I'm able to reflect both those things.
It was fantastic. I ended up reading that story, and I think it was a great story. And what was great is that, again, how many years out we've been since the pandemic, and it's kind of like this thing that we had like that happened to us, right? And we kind of like put it kind of back on the shelf and kind of things that move forward. But reading that story kind of reminded me of all these things that I had forgotten about, right? Where all these different wards turned into a COVID ward, right? So like What happened to, post-surgical? What happened to, the cardiac telemetry unit? They all became like the COVID quarantines. And early on in the pandemic, you talk about in the story about how scarce the hospital gowns were, right? And all the PPE equipment. So if you went into a patient's room, you didn't want to waste the gown. So it's like you had to do your best to try to be able to get a session out of the patient, which I even still think right now, what's great about like kind of reading that story is that it highlights all these things that we do in acute care. And it's funny, we had talked about the humanities, right? There's definitely truths that you can get out from scientific writing, but I feel reading that story, there's so many truths that even though it's fiction, but it's just, just the fact I get to read a story with an acute care physical therapist as a main character, which is pretty awesome. But it did make me reflect about my experience as a therapist, right? Having to establish that rapport with the patient. And I think the way you characterize the patient and that back and forth banter between the patient and the therapist, your character Dylan in the story, and how they would go back and forth. And I think it just highlights how much value and how important that relationship building is, and how important that's going to be in order for you to get your patient to trust you and to be able to garner that trust. And I think that's the magic pill right there. If you can get a patient to trust you, you're going to get them to be able to do things that they never thought they'd be able to do.
Exactly. That's the game changer. That's where it starts. You can't do anything else without that.
Right. But it does take you, there's some skill. I know just working with my students, the ones that have a hard time with communication, it's hard to have that confidence to go in there and get rejected. Oh, not today. It's like, oh, well, actually, I think what was the line? It's like, oh, when my mom calls me honey, it's poison when she uses that. It's a poison to the dart when she uses that. And when you're able to take what they give you, like there's a little bit of give and take. When you're able to take that, you can use that to kind of help get them on board. And I think, again, similar to a lot of our experiences in acute care, your patient was kind of fine, and like, you can help me to the bathroom. That's about it. Like, oh, okay, sure. So I think that's great, just highlighting those stories. And again, with my students, the ones that have shadowed me, that will go and walk to the patient's room, and same thing, they're just like, oh, I'm not working with you today. It's like, well, why don't we just try this? And the first thing they'll say is like, oh, if they told me no right away, I would have just walked out. But if you're able to establish a little bit of that rapport, a little bit of that trust, you can gain some of the trust, and then you can have a fruitful therapy session afterwards.
Exactly. It's an investment, I think,
Absolutely.
like trying to connect with somebody on a social level. It's an investment. It's going to pay off.
Exactly. Well, Galen, anything else you want to share with us in terms of preparation, or just to kind of advertise the webinar for July 30th?
Oh, thank you. Thank you for reading my stories too. That was really sweet. I'm special shout out to Gabby Byrne, was the OT that I presented with in Houston. And unfortunately, she was not able to present this webinar, but I have another wonderful colleague, Emma Kiernan, who has stepped in. So she and I will be presenting the webinar at the end of this month.
Fantastic. Well, what we do now at the end of our podcast, we do this thing called rapid responses. All right. And so, Galen, this is our final part of the podcast. I'm going to time you for a minute. Let me set up my timer here. And what's going to happen is, just like in the hospital, rapid responses got to be fast. I'm going to hit you with some rapid fire questions, and you just say the first thing that comes to your mind.
Okay, I just got nervous, but okay, I'm ready.
Ready to play? You got this.
All
right, let's go. All right, Galen, your most favorite way to exercise?
Running and salsa dancing.
Fantastic. Awesome. If you had a theme song before you walk into a patient's room, what song would that be?
The opening theme song to the show, The Mindy Project, which was a great show. I just love that song. So that would be it. It's very upbeat and whimsical.
Fantastic. Describe your perfect pizza.
Oh, controversial. I love pineapple, I love spinach, and I love onion on my pizza.
Fantastic.
Sometimes with a barbecue sauce instead of a tomato sauce. Yes.
There we go. Are you Android or Apple?
Apple.
Your favorite outcome measure to use while you're on acute care?
Oh, that's a good one. 5 times sit to stand. It's super easy. Don't need anything other than a chair.
Fantastic. If you were not a PT, what would be your profession?
I think I would love to be a writer. I think that would what it will be.
Fantastic. Name one PT who has been influential in your career.
Oh, Mary Fisher. She was also on this podcast before. She trained me, and now she's my colleague.
Shout out to Mary Fisher. Awesome. And final question, Galen. You're working on acute care when, finish the sentence.
You are unfazed by Am I allowed to curse by shit?
Sure. Right. It's like, man, this is part of it.
Yeah.
And again, when I look at my students or new grads or people that are not familiar with the acute care, they're just up in arms. They're just like, yeah, this is a Tuesday. This is a Wednesday. This is what
Can
we
I tell you a
do.
secret? That when I was 10 minutes late to our meeting because I was cleaning up a big mess.
That's part of acute care. That's why I said, like, I totally understand if you're running late, because I totally understand patient care. That's primary. That's paramount. Not a problem. Galen, if people wanted to find out about you or maybe read some of your writings or wanted to contact with you, how is the best way for them to reach out to you?
Oh, you can email me. I think my work email is Galen, Galen .Schram, SCHRAM at NYU Langone.org.
We'll add that in the show notes. And again, hopefully people, please don't miss the webinar. It's going to be a great webinar. We've got fantastic speakers, both PT and OT. Hope to see you then. Galen, thanks so much for being on the podcast today.
Thank you. Thanks for having me, Leo. It was fun.
We would like to thank Galen for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. This episode was hosted by Leo Reglas, executive produced by Katie Brito and Edward Battles. Music by Alexia Action from Pixabay, sound effects also from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us in 2 weeks for an engaging conversation with Ethel Fries. Thank you for listening, and may your shoes and scrubs stay clean today.